Hi, hello, and welcome to today's class. I'm sure that you all are aware of the fact that many systemic diseases, disorders, and conditions prove to be risk factors for periodontal disease. Although periodontal disease is primarily formed by bacterial origin, researchers have proved that systemic factors are known to play an additive role in the pathophysiology of periodontal disease. Having these in mind, I, Dr. Santo Grace, would like to take you through today's class on the influence of systemic disease on the periodontium. Our contents are effect of endocrine disorders on the periodontium, effect of female sex hormone on the periodontium, effect of hyperparathyroidism on the periodontium, effect of hematologic and immune disorders on the periodontium, effect of genetic disorders on the periodontium, nutritional influences on the periodontium, effect of congenital heart disease on the periodontium, effect of metal intoxication on the periodontium, and effect of stress on the periodontium. Moving on to endocrine disorders. The most common endocrine disorder is diabetes. It is an extremely important disease from a periodontal point of view. Two forms of diabetes are known: diabetes mellitus and diabetes insipidus. Diabetes mellitus is a complex metabolic disorder characterized by chronic hyperglycemia. It occurs by diminished insulin production or by diminished insulin action. Diabetes mellitus can further be of two types, of which the type 2 non-insulin dependent diabetes mellitus is the most common form of the disease. The oral manifestation of diabetes mellitus include chelosis, mucosal drying and cracking, burning mouth and tongue, diminished salivary flow, and alterations in the flora of the oral cavity, with an increase in Candida albicans, streptococci, and staphylococci species. On the periodontium, the clinical features may be enlarged gingiva, sessile or pedunculated gingival polyps, polypoid gingival proliferation, abscess formation, periodontitis, and loosened teeth. The link between diabetes mellitus and periodontal diseases may be explained by three mechanisms: bacterial environment, polymorphonuclear neutrophil function, and altered collagen metabolism. Increase in glucose content is seen in blood and gingival fluid of patients with diabetes. This alters the oral microflora, leading to an increase in anaerobic vibrios, actinomyces species, and capnocytophagia species at the subgingival flora. Also, an increase in Aggregatibacter actinomycetum comitans and Porphyromonas gingivalis has been seen. These bacteria are the primary etiologic factors of periodontal disease. The next mechanism is deficiency of polymorphonuclear leukocyte function. Diabetes patients are known to have PMN function deficiencies. This leads to impaired chemotaxis, defective phagocytosis, and impaired adherence. This defect of the polymorphonuclear neutrophils and monocytes leads to inadequate defense and thereby facilitates bacterial proliferation, leading to periodontal disease. The third link is altered collagen metabolism. Chronic hyperglycemia affects the synthesis, maturation and maintenance of collagen and extracellular matrix. The proteins and matrix molecules undergo a non-enzymatic glycosylation, resulting in the formation of accumulated glycation end products AGEs. This formation of AGE occurs in normal glucose levels also, but is excessive in hyperglycemia. The collagen is cross-linked by AGEs, making it less soluble, thereby leading to impaired tissue integrity. As a result, this leads to increased pathogenic collagen breakdown, and thereby the tissue becomes less resistant to periodontal infections. These are the various mechanisms connecting diabetes with periodontal diseases.